Hello and welcome. I'm Adele Gauthier, Research Manager at Breast Cancer Foundation NZ. And today we're talking about latest breast cancer research. First, a little bit of formal housekeeping. Could you just click on that slide for me? I encourage you to make the most of the chat box. At the bottom of your screen, you'll see a taskbar or a status bar, or if it's not down there, you might have to move your cursor down to make it appear. On that bar, you'll see a chat icon. Click on that to open the chat box. And if you have any technical issues, you can type details of your problem there and our support team will get in touch. You can use the chat box during the webinar to ask us questions, which we'll get to later. And you can also chat to other people there. Don't worry about missing out on information while you're chatting. The webinar is being recorded and will be available on our website tomorrow. You should be able to see whoever's speaking in a small box on your screen. There are some size bars just above that you can choose if you want to make it bigger or smaller. So, breast cancer research. Every year, hundreds of research studies are published into breast cancer. Some are very early research and won't mean anything to patients for many years, but others might change the way we do things quite soon. Tonight, we're going to cover some recent research news and some current clinical trials that could have an impact on us here in New Zealand. We're going to do that with the help of our three panellists, Dr. Maria Pierce, Dr. Ruben Broom, and Nurse Natalie James. First, let me introduce Dr. Maria Pierce. She's a radiation oncologist. Oops, sorry. No, I'm not going to introduce Maria first. Actually, I'm going to talk to you first a bit about a study that came out recently into breast screening. It's the UK age study. It came out in August this year in Lancet Oncology, and it looked at the effect of mammographic screening on people aged 40 to 49. The study asked, what's the effect of mammograms at ages 40 to 48 on breast cancer mortality? So let's put that in some context of how we do breast screening here in New Zealand and in the UK. If you're enrolled with Breast Screen Aotearoa, you'll know that you get free mammograms every 2 years from age 45 to 69. And that the government is committed to upgrade that to people aged 74, women aged 74, but that hasn't actually happened yet. In the UK, they do things slightly differently. They have free mammograms for women aged 50 to 70, and they're currently trialling extending that down to age 47 and up to age 73. And like us, they do this every 2 years. So what did this study do in the UK, this UK age study? It was a very large study. 160,000 women aged from 39 to 41 were enrolled in the study across 23 different breast screening units around the UK. A third of them were given annual mammograms up to age 48, and the other 2/3 had standard care. That is, they were invited to start their mammograms at 50 years old. They enrolled between 1990 and 1997 and were followed up for nearly 23 years, which is a very long time. So what were the results? When you look at these results here, it's really important to remember that they refer to all 160,000 women in the study, not just the ones who got breast cancer. So there was, across that whole population, a substantial reduction in breast cancer deaths in the first 10 years for the women who had yearly mammograms. After the 10 years, that didn't really hold up. People leveled out after the first 10 years. There was no real increase in overdiagnoses. That's something that we worry about with breast screening. We worry about finding cancers and treating them when they never would have caused the woman's death anyway. Overall, the study found that slightly less than one breast cancer death was prevented per 1,000 women screened from age 40 to 49. So what did they conclude? Well, the researchers concluded that starting mammograms at 40 instead of 50 and doing them every year could potentially reduce breast cancer deaths. So why do they say could potentially when we also see that there was a 25% relative reduction? Well, first up, let's just understand that term relative reduction. When we say a relative reduction, we mean if 2% of the population would have died of breast cancer, 1.5% died in that group. So that's a 25% reduction. So looking at this study, as we said, it was a very large study and it took place in a screening program quite similar to New Zealand. So those are good points for comparison. But the researchers pointed out that over time, mammogram technology changed during the study. We moved to digital mammograms, which we use in New Zealand now. So that may have changed the number of breast cancers that were found and how quickly women were diagnosed. And treatments also changed over that time, and that may have had an impact on how many people died of breast cancer. As we know in New Zealand, when you add more people to the mammogram program, it's a big workload for the mammogram centres. And in the UK, some centres did drop out due to workload, so we don't have the results from those centres. And the last limitation we've got there is not one that the study researchers pointed out, but one that we always consider when a study only looks at breast cancer mortality, the people who die. It doesn't look at other aspects such as having your breast cancer found early so that you need less surgery or that you don't need chemotherapy, for example. And we consider those to be real benefits of early detection, but it's not measured in a study like this. So how does this change here? Well, breast screen Aotearoa won't be moving to annual mammograms from 40 in the foreseeable future. We can safely say that. We're still waiting for the upgrade for women aged 70 to 74, which we know will save a lot of lives. But Breast Cancer Foundation does recommend that women consider having mammograms annually from 40 to 49. And that would mean that from 40 to 45, you have to pay for it yourself. So that's a big consideration for many people. And then in the next few years, you'd have them alternately free in breast screen Aotearoa and paying for every second one. So it's quite a big decision. But we do recommend that recommendation stays in place as a result of this research. And we know that in the UK, they're looking closely at the numbers from this study to see if they should be making any changes there. So if and when that happens, we'll keep you posted. Now we really are going to hear from Dr. Maria Pierce. She's a radiation oncologist at Auckland Hospital and in private practice, and she specialises in breast cancer. Maria's going to tell us about some recent radiation oncology studies, plus a couple of clinical trials that are running in New Zealand right now. So Maria, what's changing in radiation oncology?
Thanks, Adele, for asking me to be on the panel, and thank you to all you out there who have taken the time to join us at this very busy time of year. Things are always changing in radiation oncology, and we are always striving to make things better for our patients. And the way we do that is through clinical trials and research. So tonight, I'm going to talk to you about 4 clinical trials, 2 which have published their results this year, and 2 which are recruiting, and we're actually recruiting to them in New Zealand. So excuse the pun, but let's fast forward and get on to the first trial. So this is called the Fast Forward trial, and basically the majority of women who have a lumpectomy, so they have the breast cancer removed from the breast and they keep an intact breast, need to have radiation to reduce the risk of cancer coming back in the breast. And so this is really difficult for patients because we've only got 7 public radiation centres throughout New Zealand, so women have to travel long distances. Often they have young families, they are working, they've got a lot of commitments, and leaving home and travelling long distances to have treatment is a big ask for these women. When I first started in radiation oncology, we used to give the radiation Monday to Friday for 5 to 6 weeks. So this is over 20 years ago. And then we had some studies that came through where they looked at giving a bit more each day and giving it over 3 weeks. And what we found was 3 weeks is as good as the 5 weeks. So we've been currently giving 3 weeks of treatment. Now, Fast Forward trial is very exciting because what they actually did in the UK was they compared giving just 1 week of treatment, so just 5 treatments, with our standard 3 weeks, Monday to Friday, 15 treatments. And they found that 1 week of treatment, so just the 5 treatments, was just as safe and just as effective as 3 weeks of treatment. And these results are out to 5 years. So this is much more convenient for patients and also less expensive for them. They don't get that financial loss. My little cartoon there with women with breast cancer, they're busy ladies, they've got kids, they run the household, they work, and they've got a lot on their plate, so they don't need to be coming for treatment for a long period of time. So I was encouraged to put some graphs on, and I'm sure my colleague Dr. Broom will have plenty of graphs for you, but I've only got two. So this is the graph showing the results of the trial, and basically what they found was 3 weeks of treatment had a 2.1% risk of recurrence, whereas the patients who had 1 week of treatment had a 1.4% risk of recurrence. Now, I'm not going to get into the stats, but basically those results, one is not superior to the other, and one is not inferior to the other, so they're the same. So what's next? So treatment as per the Fast Forward trial is being offered in centres in New Zealand for women with low risk breast cancer. So these are women with invasive breast cancer. Patients with DCIS, or what we call in situ breast cancer, were not included in the study, so we can't offer it to them. Patients with grade 1 or grade 2 cancer, they can't have cancer in the lymph nodes because we're not sure if it's safe to give 1 week of treatment to the lymph nodes yet. You've got to be estrogen positive, HER2 negative, and some centres are offering it in women older than 50 and others older than 60. So what we know to date is after 5 years of follow-up, 1 week of treatment is as effective as 3 weeks, and side effects and cosmesis, so cosmesis means how the breast looks, is not worse. But what we don't know is if with further follow-up, these results will come through and it will be just as good. So that is one thing that we just don't know. Sometimes things change, sometimes they don't. So the next trial I'm going to talk about is the Target trial. So this is once again a trial in women with very early breast cancer who are having a lumpectomy, and standardly those women once again would have the three weeks of external radiation. And what they did in this trial was they looked at giving radiation during the operation instead of giving 3 weeks of radiation to the whole breast. So what happens is the surgeon takes out the breast cancer and then we pop an applicator into the breast, and that delivers the radiation over 20 to 30 minutes. And that's the radiation for that patient. They don't need, most of those women don't need to have external radiation. So this is kind of a one-shot treatment at the time of surgery. So what did they find? They found that the cancer control was not inferior in people who had radiation during surgery. 80% of the patients that had radiation during surgery did not need extra radiation. They had fewer side effects, less pain, and their quality of life was better if they had radiation during surgery. Radiation during surgery was previously available in New Zealand in the private sector, but is no longer available in New Zealand at all, which is a bit sad, but is available in Australia. So more graphs for Ruben. So these are the final results of the Target A trial. So the graph on the left just shows the chance of cancer coming back in the breast, and the red line is the intraoperative radiation, and the blue line is the ladies who had external beam, so no difference. No difference in women who needed a mastectomy after treatment, no difference in the chance of dying of breast cancer. Interestingly, the chance of dying of non-breast cancer causes was actually better in the intraoperative, the people who had radiation during surgery, and we're not quite sure why that is. So now I'm going to move to the Expert trial, which is a trial that is currently recruiting patients. And what they are trying to establish in this trial is if a woman has very early breast cancer, can we actually avoid giving them radiation? So what they're doing is they're looking at patients who have got very early breast cancer, and half of them will get no radiation and hormone treatment, and the other half will get hormone treatment alone. So what we're hoping to find is that if patients do have very early breast cancer, we don't have to give them radiation. And this is an international trial. This trial is currently open at Waikato, Palmerston North, Wellington and Christchurch. And once again, the eligibility criteria for this trial is women with very early breast cancer. They have to be over 50, grade 1 or grade 2 tumours, small tumours, so less than 2 centimetres, estrogen positive, HER2 negative, and no evidence of metastatic disease. Okay, the last trial I'm going to talk about is the POSNOC trial. So this is looking at women who have got breast cancer, and it's spread into 1 or 2 of the lymph nodes in the armpit. And currently the standard treatment is either to do further surgery to remove the lymph nodes from the armpit, or to give radiation to the lymph nodes in the armpit. So this trial is looking to see if it is safe not to do any further treatment in women who have cancer in one or two of the lymph nodes in the armpit. And the reason we're doing this trial is a treatment of lymph nodes in the armpit can cause lymphedema or swelling of the arm, which can impact on quality of life for a lot of women with breast cancer. So if we do find it safe to not treat the armpit, it would be beneficial to a lot of women with breast cancer. So this trial is running in the UK, Australia and New Zealand. So in this trial, the patients with 1 to 2 lymph nodes involved will either be put in a group that has surgery or radiation to the lymph nodes or no treatment to the lymph nodes. The patients will still get their usual chemotherapy, their hormone treatment and radiation to the breast or chest wall. So this trial is currently open in Auckland, Waikato and Palmerston North. And once again, eligibility criteria for this is small tumours up to 5 centimetres in size. They need to have 1 or 2 lymph nodes with what we call macrometastases. So that means the tumour in the lymph node is 2 millimetres or larger, and they need to be fit for auxiliary treatment and ongoing treatment. So very exciting. If we could avoid treating the armpit in women with breast cancer, we could save a lot of side effects.
Great, thank you so much, Maria. That was very interesting, and we'll talk a little bit later about how you might access clinical trials that you've heard are going in New Zealand. Now we're going to hear from Dr. Reuben Broom. Reuben is a medical oncologist in public and private practice in Auckland, and he's got actually a great reputation for keeping up with the latest research and his involvement in many clinical trials. So he's going to tell us about a trial that released results recently, and in fact it's one that some of you out there watching may have even participated in. Thank you, Reuben. Just let us know the latest news on your clinical trial.
Thank you very much, Adele, and thank you to the Breast Cancer Foundation for arranging this webinar, and thank you to everyone for attending this evening. So the trial I'm talking about this evening is the MonarchE trial, and the rationale for this trial was based on the fact that patients who have hormone-sensitive breast cancer, the mainstay of their therapy is anti-hormonal therapy. But in patients who have high-risk features to their cancer, they still, unfortunately, have a significant risk of recurrence. That risk is actually stretched over 20 years, but there is a significant risk in the first 10 years. The abemaciclib is what we call an oral CDK4/6 inhibitor. So it's kind of thought, it's almost thought a little bit about like low-dose chemotherapy. It blocks progression through the cell cycle. All cells in the body undergo a cell cycle, and cancer cells are undergoing that cell cycle process more rapidly than other cells in the breast. And if you like to think of abemaciclib blocking progression through the cell cycle, if you think of it like a 12-hour clock, it, for instance, blocks progression from the 7 o'clock to the 8 o'clock position. Now, this is a drug that is registered for use in patients who have advanced or metastatic breast cancer, and it adds benefit in terms of prolonging the time to cancer growth in these patients when added to standard anti-hormonal therapy, such as an aromatase inhibitor or fulvestrant. So based on the fact that this drug is registered in a number of countries for advanced breast cancer, the next step is to bring it forward and evaluate it in the early stage breast cancer setting to see if it's used in that setting, whether it can reduce the proportion of patients who have recurrence of their disease. And that formed the rationale for this trial. So this trial only enrolled patients who had higher risk features to their tumour. In particular, we're talking about patients with nodal involvement to their breast cancer. So patients were eligible for inclusion in the study if they had hormone receptor positive breast cancer, so staining for the estrogen receptor and the progesterone receptor, and they had lymph node involvement. They either had to have at least 4 lymph nodes involved, what we call N2 disease, or N1 disease, 1 to 3 lymph nodes involved with another, what we call adverse prognostic feature, and that could be one of either a larger tumour size, greater than 5 centimetres, a high grade to their tumour, or an elevated Ki67, which is what we call a proliferation index. And patients were randomised once they'd finished their primary treatment, and for most of these patients had chemotherapy because of the risk associated with their cancer, they were randomised to receive standard anti-hormonal therapy. In this patient population, these patients would be encouraged to receive 10 years of anti-hormonal therapy as being superior to 5, and half the patients also received abemaciclib for 2 years, and the other half of patients received the standard anti-hormonal therapy. There was no placebo component to this trial. And then patients were followed and observed closely to see if there was any problems or recurrence that developed from their breast cancer. And this slide depicts the baseline patient demographics, almost entirely female population. Majority of patients had adjuvant or post-operative chemotherapy or pre-operative chemotherapy based on the risk associated with their tumours. And this slide depicts some of the breast cancer features. So there should be another slide coming up here. So around 60% of patients had 4 or more lymph nodes involved, so quite a high nodal burden. And about 40% of patients had 1 to 3 lymph nodes involved. And of those patients with 1 to 3 lymph nodes involved, they also needed another adverse prognostic feature, so that would be tumour size or high Ki67, but majority of patients enrolled in this cohort were enrolled based on their high tumour grade, which is reflective of a more rapidly dividing cancer. Most of the patients, over 2/3 of patients, received aromatase inhibition. If they were premenopausal, that required ovarian function suppression with a drug like goserelin, which is Zoladex, or triptorelin, or they could have had ovarian function ablation, which is by way of oophorectomy. A smaller proportion of patients, just under 2/3, had tamoxifen. We would encourage patients who, I'll come to this in a minute, but we would encourage this patient population to receive aromatase inhibitors based on the clotting risk associated with abemaciclib. I'll come to that in a minute, but this is the primary endpoint analysis. So this was looked at, we call invasive disease-free survival, and this is the estimated 2-year invasive disease-free survival for patients. And you can see that there's actually what we call the risk of recurrence was reduced by 25%. Now that's a relative risk reduction, but in actual fact, when you look at the absolute risk reduction, the benefit is actually more modest than that relative risk reduction, because you're looking at absolute numbers, and you can see the absolute difference in invasive recurrence events was only 3.5%, which was significant, but you've got to remember you're talking about an 88.7% of patients on the control arm remaining disease-free at the 2-year mark versus 92.2% in the arm receiving abemaciclib. So most of the patients are still doing well at this 2-year mark, but this was a significant difference. Now this included local recurrence and contralateral breast cancer. And what's even perhaps more meaningful is this next slide, which is distant relapse-free survival, because that looks at the proportion of patients who remain free of cancer elsewhere in the body, which is most important. And when you look at the relative risk reduction, you're getting a 28% relative risk reduction, but when you're talking about absolute risk reduction, you're talking about a 3.3% difference, favouring the group of patients who received abemaciclib, increasing from 90.3% to 93.6%. So seemingly both arms doing well, but the patients who are receiving abemaciclib are doing significantly better. The next slide depicts the main adverse events associated with this drug, and you can see that diarrhea is the most common adverse event, and that could be severe or grade 3 in quite a number of patients, but could be controlled usually by anti-diarrhea pills. There was more fatigue. There was more neutropenia, that's a lowered white cell count, and why the lowered white cell count commonly occurred, it wasn't associated with a significant increased risk of infections associated with low blood counts. Interestingly, there was less aromatase inhibitor type side effects in the patients also receiving abemaciclib including less arthralgias. And one of the theories for that was because perhaps these new emergent side effects associated with abemaciclib was perhaps masking or dampening down some of the typical endocrine side effects from the aromatase inhibitor. A couple of rare side effects, and it's important. I mean, while this drug represents a big development in patients with this subtype of breast cancer, there was some significant but rare toxicities, including an increased risk of clots in the lungs, 2.3% versus 0.5% in the abemaciclib arm. So that is a risk, and tamoxifen also can increase the risk of clots in the legs and lungs. So if possible, I'd urge these drugs not to be combined together, and instead the better anti-hormonal partner would be the aromatase inhibitor. There was also 2.7% of patients developed lung inflammation. So this drug, while it represents a significant development, is not without some serious toxicities. So in conclusion, this is the first CDK4/6 inhibitor to show benefit in patients with early stage breast cancer. And while it was a significant reduction in the risk of recurrence, and including a significant reduction in the risk of recurrence elsewhere in the body, which is a very meaningful endpoint. No new safety signals, and so this represents a big development. So thank you.
Great, thank you so much, Ruben. So just a couple of quick questions before we move on. So this study was running in New Zealand. How many Kiwi patients would have been involved, do you think?
We had, I think, 43 patients in New Zealand. So I think we had 32 in Auckland, and then there was the remainder of patients were in Waikato, Palmerston North.
All right, excellent. And in terms of what might happen next with using abemaciclib in this way, as you said, it's not an approved use of the product at the moment, is that right?
No, so even in the US, this drug is, while the drug is registered over there, it's only for patients with advanced cancer. So we're still waiting that adjuvant or post-operative label or indication in the US. And so whether that indication extends or the company applies for that indication in New Zealand will remain to be seen. Interesting, the drug that perhaps you're more familiar with, palbociclib, which is another CDK4/6 inhibitor, which is registered in New Zealand and fully funded for patients with advanced breast cancer of the subtype. The trials that looked at palbociclib in the early stage setting post-operatively were negative. So there was a trial called the PALACE trial, which did not show benefit for the addition of palbociclib. In saying that, that was done in a lower risk patient population overall. So this MonarchE trial is specifically looking at a higher risk patient population, and perhaps that's why we see a significant benefit. We do need longer follow-up, like this is only 2-year follow-up. We do, as I said, the risk from these cancers is stretched over 20 years, so we need much longer follow-up to see whether these curves keep diverging or they come together over time, because I think that will influence how enthusiastic we are about using this drug in New Zealand or not.
Right. So a Kiwi woman diagnosed today with that kind of high-risk early breast cancer, is there anything she can do with this, or?
Not easily at the moment. I mean, we wouldn't say we're comfortable extrapolating this data to another agent of the class, such as palbociclib, especially when the palbociclib adjuvant trial was negative, and also another palbociclib trial, an LPB trial, is apparently negative as well. So at the moment, I think this is important information to discuss with patients, but it would be the enthusiasm for using it off-label is still somewhat tempered by the fact that we do need longer follow-up.
Great, okay, so we'll watch this space for a couple more years. Great, thank you so much, Ruben. Our next speaker is Nurse Natalie James. She's the lead nurse here at Breast Cancer Foundation NZ. She's going to talk to us a bit about a study of a new kind of drug called a biosimilar. And she's also going to talk a little bit about exercise during and after breast cancer treatment. Natalie, what have you got for us?
Thank you. Oh, sorry, wrong slide is what I've got. So thank you. Adele asked me to talk about a biosimilar clinical trial because there is soon to be some funding changes and availability of this type of drug in the breast cancer setting in New Zealand. And in March 2020, Pharmac indicated that it would issue a request for tenders for a reference drug, trastuzumab or Herceptin, which many of you will know about. And also in New Zealand, Southern Cross Healthcare has recently announced that it will fund a trastuzumab biosimilar drug for eligible members. Biosimilar drugs are used widely in cancer and widely overseas. And in Europe, 70% of the Herceptin market is met by biosimilars. So the small graphic there is the paper that I'm quickly reviewing for you. So biologic drugs are very specific drugs. They're used in cancer care to target cancer cells and alter the cancer cells' behaviours. They're complex medicines and they're made from living cells or organisms. They're produced in living systems. In breast cancer, a common biologic drug is trastuzumab, or commonly referred to as Herceptin. Biologic drugs work by adhering to cancer cells and stopping them grow, or they can activate the immune system to attack the cancer cells, or simply just work by helping the chemotherapy to work better. Biologic drugs in cancer care and in breast cancer tend to be first in innovative medicines, and they have a significant impact on the survival of particular types of breast cancer. And to show the survival, this class of drugs have undergone extensive clinical trials to make sure that they're safe and effective. The thing to remember though is, as with all drugs, there are often downsides, and particularly with these biological drugs, they can be very expensive, particularly during a period of time when they have a patent. So biosimilar drugs are chemically made drugs and much more easily replicated than biological drugs. They're not exactly the same as the biologic drug that is the reference drug, but these differences in molecular formation don't affect the way it works, and these drugs achieve the same outcome in the clinical setting. Biosimilars have to undergo comprehensive testing to make sure they're safe and effective, and regulatory bodies like MedSafe in New Zealand have very strict requirements to make sure that this is done. In New Zealand, there's 2 Herceptin biosimilars that are available privately, Herzuma and Biosimilar. And next year, Pharmac is looking to fund more biosimilars across New Zealand. So the trial that I'm reporting on was research into Herzuma, and this particular study aimed to test Herzuma and check that it was as effective as trastuzumab or Herceptin for HER2-positive early breast cancer. The trial recruited 549 patients from 112 centres across 23 countries. Participants were randomised to either Herceptin or Herzuma for neoadjuvant and adjuvant treatment, and they were treated for the period of 1 year, but followed up for 3 years. The trial results were broken down into 3 areas. Before surgery, the results were reported that before surgery, a pathological complete response was seen in 46.8% of patients treated with Herzuma and 54% of patients treated with Herceptin. Now, the analysis of this was that this was a similar result. Also similar, at the end of treatment, there was complete remission seen in 49.1% of patients treated with Herzuma and 52.2% of patients treated with Herceptin. Safety was also evaluated, and the main adverse events seen for Herzuma were hair loss, nausea, infusion-related reactions, and diarrhea. Herceptin had side effects of hair loss, nausea, and infusion-related reactions. Grade 3 toxicities were also reviewed, and grade 3 or worse, and this is because these particular toxicities often need to be managed, and they were similar when looking at Herzuma-related grade 3 and Herceptin-related. So what's next? 3 years after the study, the Herceptin and Herzuma results are still being evaluated, and equivalent results are found for disease-free survival, overall survival rates, and cardiac toxicity. And as I said, these sorts of studies are important because MedSafe New Zealand is evaluating other trastuzumab biosimilars, and this should increase availability in both the private and public setting in New Zealand. The next study that I'll just very briefly touch on is research on exercise for people with breast cancer. And research on exercise is something that's been mentioned many times in the webinars across the years. This particular study has really just been chosen because it's a 2020 study, and it looks at exercise before, during and after chemotherapy for high-risk breast cancer patients. There is a lot of research around exercise and cancer outcomes, but there are limitations to these kinds of studies. Data is often collected on one occasion, and data describing associations between exercise and breast cancer can be very limited. It can often be conflicting, and it's not well understood. The authors of this study wanted to see whether exercise before, during and after treatment, particularly chemotherapy, had an impact on survival for high-risk breast cancer patients. It was a study that was run in association with a chemotherapy study in the United States, and through this study they recruited 1,340 patients. These patients were categorised according to whether they had met the minimum exercise guidelines and how active they were. They were categorised from inactive to highly active. Researchers collected data on the physical activity at several time points, before diagnosis, during treatment, and at 1 and 2 year intervals after enrolment. Patients were followed up for 15 years after their treatment, with a mean follow-up of 89 months, which is long. So what they found were that patients who met the minimum activity guidelines for exercise before and 1 year after diagnosis had the best outcomes, a greater than 50% reduction in risk of recurrence or mortality. And I'll just point out there that the 150 to 300 minutes of exercise per week were the guideline, and I think that's quite high. Mm-hmm. Patients who only met guidelines after treatment, so who were not doing the recommended exercise before diagnosis or during treatment, also significantly reduced their risk of recurrence or mortality. And patients who consistently engaged in lower levels of weekly exercise also experienced survival advantages in this study, and these became significant over time. So the summary here really is that there are limitations to studying exercise and exercise outcomes, primarily because they rely on self-reporting. Consistently meeting exercise guidelines is associated with a reduced risk of recurrence and mortality for high-risk breast cancer patients. Those who do low volume activity are also associated with statistically significant overall survival benefit. And low volume activity in this study was seen as better than inactivity. And the takeaway is for those that are having chemotherapy and those that are completing treatment, it is important to keep on moving, even if you can't do a lot or if you were inactive before you started your treatment.
Great, thank you so much, Natalie. That was very helpful. I can see a couple of questions popping up on that. Just remember at home there, if you do have questions for us, we'll get to those in just a few minutes' time. So please put those in the chat box and we will answer as many as we can. Right, I am now going to just run through with you how to find out some information about clinical trials in New Zealand and just show you what some of the information that's available looks like. On our website, breastcancerfoundation.org.nz, we do have a database of current clinical trials in New Zealand and Australia, and you can see there that we have trials that are currently recruiting, that means currently admitting patients, or that are pending, that we know are going to be opening soon. Maria Pierce here has already told you about a couple of radiation oncology trials, and I'll just tell you about a couple of the other ones that are currently open here. And you can search this database by what type of breast cancer you have, for example, if it's triple negative or if it's early or advanced cancer. So let's just look at a couple of the early breast cancer trials that are currently open. NEO-N is at Waikato Hospital, and that's looking at an immunotherapy drug plus neoadjuvant chemotherapy, that's chemo before surgery, for early stage triple negative breast cancer. I'm not going to go into much detail on any of these, just give you a rundown of what's happening. Some of you will have heard before about the PANTOSIN trial, which we talk about quite a bit and is widely open around New Zealand. And that's looking at the use of a heartburn drug to prevent delayed nausea and vomiting from chemo. That's up and running at the moment and is still recruiting patients. The next trial, Rapid EBC, is likely to be opening in early 2021 in a couple of hospitals around New Zealand, and that's looking at using intravenous iron supplements to reduce anemia during chemo and to see if that improves quality of life for people. So we'll keep you posted on that on our clinical trial database. Next, looking at some advanced breast cancer trials that are open or about to open. The first one, Innovo 123, is looking at a new drug plus palbociclib, which some of you will know as Ibrance. That's a drug similar to the one we were talking about before in Ruben's trial. Looking at that with fulvestrant in patients who have a specific genetic mutation that they would need to be tested for before they can enter that trial. And that's for a first-line treatment, which means it's for people newly diagnosed with advanced breast cancer who haven't had another treatment for that metastatic breast cancer. And you can see that's open at several hospitals at the moment. The next one, Patina, has been open for a little while at Auckland Hospital, so some of you might already be enrolled in that. And that's looking again at palbociclib or Ibrance, and if that can extend the time before cancer progresses. And patients who are using Ibrance in New Zealand generally have ER positive or PR positive breast cancer that's HER2 negative. This trial actually looks at people who are HER2 positive as well. The next trial, GDC 9545, catchy name. That's looking at whether a new drug, again using palbociclib, is better than not using it for patients with ER positive, HER2 negative advanced breast cancer. Then there's a trial that's coming up early in 2021, Tapestry, and that's a phase 2 trial, so it's a slightly earlier trial of a whole range of different drugs for people with advanced breast cancer, either that there's no other suitable treatment available for at all, so they'd be having it in first line, or for people whose breast cancers have progressed on earlier treatments. And unlike some of these other trials which specifically focus on breast cancer, this trial looks at specific tumour mutations, like we can see PIK3CA there, and ALK1 and ROS1 and various other mutations, and says if you've got this mutation, maybe this drug will work for you. So that will be opening early in the new year. And then the last treatment, the last trial, THYMIN-2, is for patients across multiple cancers, not just breast cancer, who are going to be having a type of blend of chemotherapy drugs called 5-FU. And we do know that a small percentage of patients have a really serious reaction to those drugs. This is a test that's been developed here in New Zealand that looks to predict if patients are going to have that severe reaction or not, and therefore shouldn't be given that treatment. So that's a very important study for ensuring that people have the best possible outcome of their chemo. And then there are also a couple of trials around supportive care. The first one, Kind to My Body, is I think a new trial which is looking at a self-compassion-based writing exercise to see if that can help people with body image perception when they've had breast cancer diagnosed in the last couple of years. And COFI is a new trial for younger women, aged under 50, looking at diet and exercise interventions to help manage their risk for chronic diseases and their general wellness after breast cancer. Then there's a trial on lymph node grafting for patients with lymphedema that hasn't been able to be treated in other ways. That's open to, although it's at Waikato, that's actually open to patients from all around New Zealand, so that could be an interesting one. And then if you have a BRCA1 or 2 mutation, then you may want to join the New Zealand Familial Breast Cancer Study. Not so much a clinical trial, but an ongoing watching people with BRCA1 and 2 mutations. If you're interested in joining a clinical trial, you can talk first up to your medical team, your surgeon or your oncologist or your medical oncologist or radiation oncologist, But you may also contact trial coordinators directly, and some of those contact details are on our website. Okay, that's it on clinical trials. So we'll move now to your questions, and we've got about 15 minutes left, so we'll get through as many as we can in that time. Let me see what we've got here. Okay, Ruben, I think this one will be for you. Is anyone on the panel familiar with the SOLD trial for Herceptin for 3 months versus 12 months, and what is the outcome of that?
Yeah, that has been reported. So yeah, look, from memory, it didn't. I mean, there were a number of other studies looking at duration of Herceptin, and this was one of them. The rationale for the SOLD study was because there was originally a small Finnish study which suggested that if you gave a shorter duration of Herceptin compared to no Herceptin, the relative risk reduction for recurrence was similar in the much larger studies that looked at a year. But and that formed the basis for the SOLD trial, but there were also several other studies looking at 6 months versus 12 months of Herceptin. And the problem is with these studies is it's non-inferiority trial design, and so the statistical analysis gets quite difficult. But you're trying to prove non-inferiority. One of the 6 versus 12 month studies met its pre-specified non-inferiority endpoint, and the other one didn't. So the whole sort of duration of Herceptin question remains. You can look at data to support a shorter duration, including 6 months, and you can even look at the subset analysis of the SOLD trials, and it suggests that there are a proportion of patients with lower risk HER2-positive breast cancer who can get away with even shorter 9-week duration of Herceptin. But I think when you look at the 2 large 6 versus 12 month studies of Herceptin, on balance, you'd have to say the standard duration is still a year, but if you've got a lower risk HER2-positive breast cancer, then you can get away with a shorter duration and arguably less side effects.
Right, great. Okay, thank you for that. And I think there were a few New Zealand patients in the SOLD trial as well, so that may be why someone was asking about that. Right. Now, a question around exercise studies. Are the studies results for all types of breast cancer, or are there differences depending on the type of breast cancer the patient had? We can't really comment on that for this specific study.
No, this particular study was for patients having chemotherapy. So they were early breast cancer patients, and they did report that in the trial. But we are aware of a study in Auckland looking at patients with metastatic breast cancer. So I think it's fair to say that there are studies looking at all breast cancers. Yeah.
Yes, and certainly studies of risk of recurrence after exercise haven't differentiated between different types of breast cancer, and it's a recommendation across the board that people stay active as far as they can after treatment, and now during treatment. Increasingly studies are saying during treatment, so that's very important. Now a question around radiation oncology for Maria. The fast forward treatment, does giving the higher dose over 5 days cause increased side effects? So there were 2 doses, weren't there, over 5 days? And that
Yes,
doses? Yeah.
So basically what they did was they compared the standard 3 weeks, 15 treatments with 2 doses over 5 treatments. The higher dose over 5 treatments did give more side effects, but the lower dose over 5 treatments had similar side effects to the 3 weeks treatment. The question is, with radiation, you can get ongoing side effects after 5 years, and the question is, if we follow people longer, will the side effects be worse in the 5 treatment arm? But we don't know the answer to that, and it may not be.
So the lower and the higher doses both had similar outcomes so far in terms of recurrence?
Yes.
So the lower dose was considered acceptable.
Yeah.
And so would the lower dose be what's being used here in the studies? Great. Okay. In practice rather. Excellent. Okay. Ruben, sorry to put you on the spot here, but a couple of people have asked about new trials in triple negative breast cancer. Can you give any thoughts on that?
Yeah, I mean, arguably, you mean new trial results? Yeah, I mean, probably the most interesting drug in triple negative breast cancer is sacituzumab govitecan, IMMU-132, which is a anti-TROP2. It's a TROP2. It's basically got it's an antibody drug conjugate, so it's a large molecule directed against TROP2, which is overexpressed on not all but most triple negative breast cancers, and then attached to it via a linker molecule as a potent chemotherapy. So that antibody drug complex gets basically absorbed into the cancer cell and spares, or supposedly spares the body a lot of the toxicity of the chemotherapy drug. It does still have quite a bit of toxicity, including quite a significant risk of infection, but it seems to be one of the new very active drugs for triple negative breast cancer. Not yet in the country, but hopefully we'll see it at some stage. And then there are there's some interesting trials with novel immunotherapies, including pembrolizumab and atezolizumab in combination with chemotherapy in the first-line setting. So the benefit of these immune checkpoint inhibitors in breast cancer seems to be when they're given earlier on, and essentially confined to patients whose tumours are PD-L1 positive. So testing for PD-L1 is really required to see whether patients are going to benefit significantly from these drugs, which also have a lot of side effects, immune-mediated side effects. So, thanks.
Great, thank you. And now a question probably for both of you around some of these studies where we say they were for postmenopausal or premenopausal women. Why is that decision made, Maria, in radiation trials for start? What's that?
Yeah, I think the feeling is in older women with breast cancer, they tend to have lower risk breast cancers, their risk of recurrence is lower. And so those women, if you're going to trial without radiation, then those are the first ones you would probably trial without radiation. So it's based on sort of postmenopausal women with low risk breast cancers, yeah.
Mm. And is that the same rationale with drugs?
Yeah, I mean medical oncology trials, like the one we discussed earlier, it's really if you're postmenopausal versus premenopausal, then the anti-hormonal therapy options are slightly different. I mean, in both pre and postmenopausal, and patients with high-risk disease would encourage a trial of aromatase inhibition. And in premenopausal patients, they also require ovarian function suppression with a drug like goserelin or Zoldex in order for the aromatase inhibitor to work. So I don't know, it's kind of like a standard sort of demarcation of sort of identifying what the population was included in the study, but obviously there's implications for what anti-hormonal therapy patients have.
And Maria, for people doing the expert or POSNOC trials, do they have a different sort of level of follow-up to check on them if they're not getting radiation therapy?
Yeah, if they're not getting radiation, they just still have annual mammograms. So for the expert trial, they'd just have annual mammograms, just as per they would if they had had a breast cancer and had radiation treatment, because doing them more frequently, there's no evidence to show that's beneficial. And POSNOC trial would have regular follow-ups examining the axilla, but as far as I'm aware, there's no extra investigations there. And
in your view, your experience with clinical trials, we're just about run out of questions here. So if you've got anything else to say, guys, put your questions in now, because we'll wrap up in a minute or two. But in terms of people wanting to get onto clinical trials, what's your view is the best way to go about it? And what's the kind of conversation you should be having with your doctor?
Yes, so I think if clinical trials are available in a centre, they're usually offered to patients. So most clinicians would offer a clinical trial to a patient. But I think you as patients, you could ask, are there any clinical trials available for me? And yeah, I think that's probably the best way to look at it. Talk to your doctors, talk to your breast cancer nurse specialist about that.
Ruben, anything to add to that?
Yeah, I don't think so. And I think it's always a good question to ask in your consultations. But, you know, as clinicians, we should also be, we should be bringing it up as well. So in fact, we should be bringing it up first, but definitely a good question to ask.
It's quite interesting. When I was did my fellowship in Canada in about 2005, every patient who came into the clinic in Canada asked about clinical trials. And you'd walk into the lift and there'd be a big picture. Have you thought about entering a clinical trial? So I think we need to probably advertise ourselves a bit better too. Yeah.
Right. Yes. Yes. Because there are, as we've seen, quite a few trials going on, and so it's worth asking about. And what about patients in private treatment? Do they have access to clinical trials?
I mean, most research is still done in public, so it's not exclusively so, but mainly so. So I think, but remember, every patient is entitled to comprehensive public care. So even if you're starting off in the private system, you can ask about your public care options because everyone is entitled to it, and it may be that there are more research options in public.
Great. Now, we did have a question from someone who said she's watching this webinar because she has severe long-term side effects from her aromatase inhibitor treatments, her endocrine therapy. We probably haven't helped you with anything here tonight. We do have a webinar on managing those side effects, which is actually our most well-attended webinar ever, so that's worth a look. And shortly we'll put up the phone number for our nurses too, that you can call them and talk to them about that. Anyone got any further thoughts on recent trials for endocrine?
I mean, aromatase inhibitors it is harder therapy. There's no doubt about it. Yeah, check out that webinar.
Now, a question here, and I don't know the answer to this, I'm not sure if any of you will. Why is the lymph node grafting trial only available for patients who don't have metastatic breast cancer? Anyone have a view on why that might be? We can inquire about that if we don't have an answer for you now.
I don't know the answer, but I know that the clinical trial coordinator is very accessible and would be very happy to answer any questions. So
yes,
my advice is to give them a ring, and I think all the contact details are on our website, but give them a ring because there's something, I think they would go through it with you.
Yeah, for that trial they're certainly very actively looking to enrol more patients, so certainly that's a really good conversation to have with them. Okay, we've just about run out of time, so let me just see what else we've got here. So yes, here's the phone number for our nurses. We have 5 expert breast care nurses on our staff who you can call during office hours. The number's there for you, and that's also 0800 BC Nurse if you forget that. And of course you can join our online community, MyBC, to connect with other patients, and that's a nurse moderated community as well, so you can talk with our nurses there. The webinar will be on our website in the next couple of days, and we'll contact those of you. We'll send you out a link for that. And then the last thing is that as you leave the webinar, you'll see an exit survey pop up. We would really appreciate if you could take just half a minute to fill that in and give us your thoughts on the webinar and anything else you'd like to learn about. So thank you so much to all 3 of our speakers tonight. You've been fantastic, and I know that's been really illuminating for the people out there. Have a great Christmas, everyone, and we'll see you at the next webinar. Good night.